posted. Just heard that we'll be able to get these recordings posted soon. So I apologize, I haven't been available yet, but we should have all of the presentations available on the Intern Teaching Conference website. So good morning, everyone, and welcome. Thanks for joining us again for Intern Teaching Conference. This is our 7th of 8 sessions this summer, so it's hard to believe that we're almost done. And before I introduce Dr. Goldberg, I just want to give you a little heads up about what's to come. So we're going to have Dr. Goldberg with us this morning. We'll have Dr. Susan Merrill with us next week, closing us out on an approach to treating pain as an inpatient. For inpatients. And then we actually are going to come back together as a group of your entire intern class on Zoom on August 27th. I believe it's the last Thursday of the month for our intern retreat. And we traditionally use the morning time to do some intern-specific didactics, which we'll continue to do. And then Ken will use the afternoon time for some team and community building. So that morning, because of COVID and because we wanted to get the COVID talk squeezed into ITC, because we thought that was really important information and material for you folks early on, we moved one of our normal ITC talks to that morning of didactics at the end of August. So that morning, and I'll send information about it like always, but that morning will be start with Ken actually talking about an approach to dyspnea. So he always gives that talk during ITC, and this year we booted him to the end, but that's okay. He was a willing participant. So we'll start that morning with an approach to dyspnea, and then we're totally going to pivot and shift gears, and Dan Cabrera and I are going to help facilitate a discussion around interrupting bias in our team interactions and working with patients. Okay, so that's the plan for that morning. So although next week is technically the last day of ITC, we're going to have one more ITC session at the end of the month. All right, and I'm going to make sure everyone's muted. I think we probably have a group of folks who just joined us who are not muted. I will find you. People. Let's see. Who are you? Can everyone make sure that you're muted, please?
How do I change my name?
JJCC is the person.
JJCC. There we go. Got it. Thank you. Okay, I know that we've got groups of interns who are together joining, so I appreciate that. Okay, and I see a couple more folks in the chat letting me know that you're here but can't use the QR code, so no worries, I'll record your attendance. All right, so sorry for the long introduction this morning. Without further ado, I am excited to introduce Dr. Allison Goldberg, who is a graduate of our program a number of years ago now, a palliative care doc and a hospitalist up at Northwest Hospital. And Allison developed this talk, again, a number of years ago now around an approach to code conversations after we heard from interns about this really critical piece of education that was missing early on, and thinking about the rapid sort of transition from fourth-year medical student to intern and how crucial these conversations are early in a patient's hospitalization. And so Allison is going to help lead us through a discussion. And we really, I'll just say, put this pitch, this is a great talk for participation, so please feel free. Hopefully we've created a community amongst ourselves via Zoom this summer, so please feel free to unmute yourself, ask questions, share thoughts, and certainly I'll be monitoring the chat. Okay, so I'm going to stop sharing. Whoops, that's not what I meant to do. I'm going to stop sharing. There we go. So Allison, you should be able to share your screen, and if you're having any trouble, just let me know. There we go. There we go. And you can just put it in presentation mode. There you go. Great. All right, Allison, take it away.
All right. Thanks, everybody, for coming early in the morning and for having me. As Gabby said, I finished palliative care fellowship and residency here a few years ago, and I'm now at Northwest. And I'm really excited to talk to you about code status discussions. I wanted to acknowledge that sometimes this topic can seem like kind of a downer. And I don't mean for that to be at 7 a.m., but I do want to invite plenty of space for your experiences so far this year, and obviously to give you some high yield sort of skills to take away. But I think part of what makes this conversation high yield at this point in the year is hearing from your peers. So as Gabby said, please feel free to type into the chat and unmute yourself and ask questions, and I will specifically ask for that, for you to do that at certain points during the talk. So I have no disclosures, and the goals of this talk are really to focus on a clear approach to code status discussions when you're in the ED admitting patients on call days. And more specifically, I want to talk about what words you should actually say when you have this conversation, how much time you should spend. I think the bias is that to feel like you're doing a good job in code status discussions, that this could take a lot of time actually talking about goals of care. And we're going to talk about how to make that a little bit more efficient and how to decide how much time you need to spend with each patient. When it is actually important to have an understanding of patients' goals of care and not just a decision about their code status. And then finally, how you document your code status discussion in the medical record. And before we get into a couple of cases that I have for you to sort of practice an approach to code status discussions, just want to give you a little bit of context about this skill. And code status discussions fit into a group of skills called primary palliative care skills. And primary palliative care skills are skills that all physicians should have. So the way that all physicians should be able to assess decisional capacity, even though psychiatrists might be most expert in that, all physicians should have these primary palliative care skills, even if palliative care physicians are most practiced in them. And these skills include screening and management of basic symptoms like pain, nausea, constipation, dyspnea, and anxiety. I'm sure you guys are already doing this with your patients on the wards. Doing a functional assessment and equipment to facilitate ADLs. And for this, we usually rely a lot on our physical and occupational therapy colleagues in the hospital to help us. Screening, but not necessarily management of psychosocial, spiritual, existential, and caregiver distress, and then usually a referral or a consult to a palliative care interdisciplinary team to help deal with these things. And then finally, a discussion and documentation of advanced care planning, including paperwork or durable power of attorney for healthcare, advanced directives, a POST form, and then the inpatient equivalent of a POST form, which is the code status discussion. So we're going to be focusing on this last primary palliative care skill this morning. I also want you to know that for whatever awkwardness we all may feel approaching, end-of-life conversations like this, patients really appreciate this. A lot of studies have shown that most patients expect their doctors to bring up advanced care planning when it's time, when they notice that their health is sort of taking a turn for the worse. And that when patients bring up these kinds of conversations, doctors often ignore cues about concerns related to dying, often because we're uncomfortable with it, or we're afraid of disappointing a patient or something like that. Evidence does not suggest that patients have more anxiety, depression, or hopelessness as a result of engaging in difficult goals of care, end-of-life conversations. And I would say, so you're not, by discussing something difficult, you're not making it harder for a patient. And I would say, in fact, a lot of times when patients have these really important things on their mind, addressing it directly can be a huge relief rather than making it harder. For inpatients and their surrogates specifically, there's been studies to show that there is no difference in satisfaction with care during the hospitalization, whether or not a difficult goals of care or end-of-life conversation has taken place. And then you probably already know, but patients who have had advanced care planning conversations tend to be more at peace and to receive less intensive care at the end of their lives. And also their family members and surrogate decision makers often have an easier time making decisions on their behalf and then also grieving their deaths after they pass. So all in all, these conversations are really good ones to have, and we'll try to find a way to make it comfortable and respectful. The last thing I want to acknowledge before we get into it is that, like everything in medicine, what we say is not necessarily what patients hear, and vice versa. And there have been a couple of studies looking at residents having code status conversations in particular. In one study, in only 63% of cases, when residents had code conversations with patients, did the patient and the resident actually agree that a code status discussion had even taken place. And in 7% of cases, did the patient recall or remember that CPR had been discussed, which is quite shocking if you think that's pretty much what a code status discussion is for. And then in another study showed that for patients and residents who had code status discussions, in more than 20% of cases, they had differing beliefs about what the outcome of that conversation was. And so to me, the take-home point there is that it's really important to be very explicit about the decision at the end of a conversation that may deal with goals and values and other things too, but not to make assumptions and to lay it out really explicitly. Any questions or concerns, comments up until this point? And then a case. We good, Gabby?
We're good in the chat. Yeah.
Okay.
Give
All
it
right.
just a second to see if anybody has thoughts or questions. I know it's a heavy topic for early in the morning, so we appreciate your engagement. Cool. Go ahead, Allison.
All right, great. I actually can't see the chat at all when I'm on full screen.
Yeah,
so.
I know. That's why I've got it. No worries.
So let's start with a case, just to kind of warm up and see where we're all at with this. This case is of a 64-year-old woman with a history of breast cancer in remission, hypothyroidism, AFib on apixaban, who comes in with a left lower extremity cellulitis. She's mildly tachycardic, otherwise vitals are normal, and she gets IV fluids, IV antibiotics, and a left lower extremity ultrasound in the ED. And she has no advanced directives. So either type into the chat, take a minute and type into the chat, or feel free to just unmute yourself and share. How would you approach her code status? How would you start this conversation with her? And how does it feel to be having this conversation with someone with this kind of medical history and presentation?
I feel like with most patients, I just start with like, this is some, wait, is this, sorry, what's the is she inpatient or is this outpatient?
She's in the ER. You've just been called to admit her and you're meeting her in the ER.
Oh, there in the ED. Okay. I feel like I usually start with, like, we ask everyone these questions and then ask about, like, DNR and DNI status.
Awesome. So some kind of normalizing statement so that she knows that this isn't about her necessarily, or what you think about what's going to happen to her during the hospitalization. This is something that everybody gets asked. Awesome.
Great. And there are a couple of thoughts in the chat also. I almost always start the conversation with, I don't expect this to come into play, but we ask everyone when they come into the hospital. So I think similar to the other person, and I'm sorry, I can't always see who's unmuting themselves. Another comment, think about first what her likelihood is of having something happen, and then what her outcome would be before approaching the conversation. Mm-hmm. Another comment, she has a single treatable medical condition, at least at this time, which generally makes these conversations easier for me, meaning the person who shared. Mm. And then I would feel comfortable having a discussion with her where I don't lean toward DNR, DNI like I might if this patient were very sick and not able to survive a code. And then another comment, ask if they've ever had a conversation about code status.
Wow, this just gets better every year. These are all really great suggestions. A lot of where I'm going, and I think for two comments, I guess, based on those things. One, I think a normalizing statement is really awesome, and I just want to be careful that we say if we don't think this is going to come up during the hospitalization that we're sure about that. If we put it in our normalizing, sentence. And I lost my other thoughts, so we're going to keep going. Thank you for all those suggestions. Oh, the other thought was, for anybody who didn't write this, is just that I think sometimes with a patient like this, who, as you noted, has one probably pretty solvable medical problem, and that this is unlikely to come up, it feels a little awkward sometimes to be talking about what to do if you actually die in the hospital. And so I just wanted to acknowledge that in language. And I think just as you guys are, what makes this a little bit easier to transition to after your end of H&P is to start with some sort of framing, because otherwise, you know, as you said, there are patients for whom you don't expect this to come up who may start worrying, oh my God, doc, am I dying? Is that what you're thinking? And I think that is behind some of our tendency to say immediately that we don't think this is going to come up and that this is sort of a formality. And sometimes that's true and sometimes that's not true. And so having some sort of framing, giving patients some context about why we're sort of transitioning to this other line of questioning or this conversation, I think is really helpful for us and for the patient. And how do you frame the discussion? A couple of suggestions that you also brought up. Sometimes I start by being really explicit and offering a preliminary diagnosis and how serious I think it is and what I think is going to happen in their hospital course. So for example, for this woman with just a cellulitis, you might just say, you have an infection called cellulitis. It's an infection of the skin and soft tissues, and it's bad enough that you need to be in the hospital and get some IV antibiotics, but most likely within a day or two, it's going to get a lot better and you can go home and finish your antibiotics as pills, right? And so then this patient kind of knows that you don't think she's that sick. Sometimes I start by asking about somebody's durable power of attorney for healthcare, and usually say something like, who would you trust to make medical decisions for you if there were an emergency and you couldn't make them for yourself? And sometimes that feels like a little bit more neutral ground than going straight to CPR and life support. And then finally, a normalizing statement of your choice that sort of communicates that we ask everyone, no matter what they're here for. Great. Moving on, after you start this conversation, I just want to spend a minute and talk about what should actually be the content of your conversation. What information do you need to cover when you have a code status discussion? And there's a fair amount of literature to suggest that a good code status discussion has all the elements of a good informed consent discussion, as it is for other medical procedures, like having a blood transfusion or a paracentesis or something like that. And those components include a discussion of the indications for the procedure, details of the procedure, anticipated benefits for your particular patient, the risks to that particular patient, alternatives, and then often end with a recommendation. And when we have an informed consent discussion about things like a paracentesis or a transfusion or something, often the implicit recommendation is that the patient get it done, right? Otherwise we wouldn't be talking about it. And for a code status discussion, that's different. So giving recommendations is sort of a different task that we probably have a variety of experience with, and we're not going to be able to get into today. But for wherever you're starting from, I would say these are the highlights, and you're probably already hitting them, even if you don't know. When I hear a lot of code status discussions, they usually go something like this. If your heart were to stop, if you were to die in the hospital, would you want me to do chest compressions and electric shocks to try to bring you back? Or this sometimes involves breaking ribs or being stuck on a ventilator, or would you prefer that I let you die naturally? And then obviously sometimes we end with a recommendation and sometimes we don't. Literature kind of suggests that residents, the bias in residents is not to offer recommendations as much as attendings do, for example, which may be appropriate in some cases, but the other bias just to be aware of is that residents often tend to underestimate the benefits of CPR for an in-hospital arrest. So just something to keep in mind. But these are the highlights, and you're probably already hitting them. So next, I just want to offer you another thought, which may be behind some of the comments in the chat already today, about the approach that I use after I sort of start with my framing and get at patients' understanding of a code status discussion and where we're going to start. So this is my approach to everyone. The first thing I want to know is, have you ever thought about this before? right? Because I'm going to try to meet patients where they're at and where they're starting from, and this is going to let me know where they're at. And so to get at this question, I usually ask something like, do you have any advanced directives I should know about? Or have you ever talked with a doctor before about things like CPR, being on a breathing machine? And some patients will say yes. And then the next thing I need to know is, great, was that conversation helpful? And I ask them, can you summarize for me what that conversation was or what your advanced directive says? And for some patients, they know exactly what you're talking about. And for example, a lot of patients I have now at Northwest will say, oh, you mean like a DNR? I have a DNR. Or will be able to pull out their pulse form for you. And if that's the case, and you're both on the same page, then you can just use the patient's advanced directive. There are other patients who will say, yes, they thought about this before, but when you ask them to summarize, they'll actually say something like, oh yeah, we filled out all that paperwork with a lawyer, it's with the lawyer. And then you say, that's great, can you tell me what it says? And they say, oh, my daughter's a doctor, she's gonna make all the decisions for me. And that doesn't really tell me anything about how they feel about CPR and intubation and mechanical ventilation. So I put these people down the no side of the algorithm. And on the no side of the algorithm, if a patient has never thought about this before, I ask myself the surprise question. I don't know if any of you have ever heard of the surprise question. It was originally intended in the outpatient setting for providers like primary care doctors to sort of ask themselves when they see a patient, would I be surprised if this patient died within the next 6 months to a year? And if the answer is no, I wouldn't be surprised, then that's supposed to be a trigger for a palliative care referral or a palliative care type conversation. And I sort of just co-opt that surprise question in the hospital and ask myself, how likely do I think it is that this patient might have to transfer to the MICU or might actually code during this hospitalization? And I sort of put my patients somewhere along this continuum of unlikely, possible, and likely. And based on where I think this patient is, helps me decide how much time I'm going to spend on this conversation in the ED, how hard I'm going to work to try to get at the values that underlie a patient's decision about code status, and then how important it is to actually nail down some very specific decisions rather than sort of just introducing the topic and, letting a patient talk to her husband about it or something and get back to me. Does that make sense? Any questions or comments up to here? Okay, great. I'm going to keep going.
Anything in the chat. I'll let you know if there's something in the chat.
With a second case, a little bit different than the first one. So this one is a 72-year-old man with severe COPD who is getting admitted with new fever, productive cough, and acute unchronic hypoxia. This is his 4th admission for a COPD exacerbation in the past 6 months. He's on BiPAP in the ED, and an ABG is pending. On his last admission, he was full code. And I just want you to think to yourself for a minute, how would you approach his code status? How do you feel about it? What words would you say when you start this conversation with him? Or just what do you think when you take a look at his clinical picture and think about having to address this with him? Feel free to also talk about it if you're in a team room with people. Okay. So if you have an idea in mind, and how you would start and looking at this algorithm kind of go down, I want to focus on the bottom part and ask you how likely you think it is that this patient might have to transfer to the MICU or might actually code during this hospitalization. Maybe you can just type into the chat whether you think this is unlikely, possible, likely, or somewhere in between.
We're getting a lot of possibles and likely. And there was just to clarify that this patient, good intern question that came through to me, this patient is able to have a conversation. I'm going to assume, Allison, he's not so hypercarbic, or what, you're able to actually have the conversation, but lots of likelies and lots of possibles.
Yeah.
Even a likely / possible, which I love.
That's exactly what I think, actually. Some likely / possible, right? So this guy's already on BiPAP. Either BiPAP is going to turn it around for him, or it's not. And if it doesn't, we're looking at a situation of intubation or comfort care, basically. And so, right, I think this patient is somewhere along here on this continuum, and which means we have to spend quite a bit of time talking about this, and in comparison to our other patient with cellulitis, for whom we don't necessarily think this is likely. Awesome. So going forward, talk a little bit about what words you should actually say, right, when you have this conversation with a patient based on their likelihood. And so start with maybe the easier one, which is this woman with cellulitis who has never thought about advanced care planning before, code status before, and for whom we don't think it's likely that this is going to come up during the hospitalization. Sometimes I just ask for assent for someone to be full code and say something like, in the unexpected event that you were to die in the hospital, would you allow me to do CPR and place a breathing tube to try to reverse that? And in asking that question and asking for assent, you'll get some feedback about whether this patient is on the same page or whether they really have different ideas about their code status. But this is, if they've never thought about it before and you don't think it's likely to happen, this approach tends to satisfy. And then for this patient with COPD, for whom we think it's possible or likely even that he could end up in the MICU or have a code, we need to spend a little bit more time. And so I sort of introduce this conversation usually saying something like, for many people with advanced COPD, there comes a time when, the best of our medical treatments can't necessarily make it better, or something like that. And I'm worried that we might be near that time now. And we don't know, and always pause when you say something like that. We don't know if he's full code because it's very important to him, or because no one has ever talked with him about this before. And then I go on to say, I hope that with BiPAP and antibiotics and nebulizers that your breathing gets a lot better. But I want to understand better how you feel about the situation that you're in, so that we have a good plan for what to do in case things don't get better. And then for people who have never thought about this before, but we actually need to nail down a thoughtful decision, like for this guy with COPD, I often give my patients choices and some context for, how they can think about this issue of code status. And usually say something like, in thinking about the medical problems they have and what's important to them in life, I have some patients who would say, I'm satisfied with my life or my quality of life, but I know I have some serious medical problems. So if I get so sick that I actually die in the hospital, please make sure I'm comfortable and just let me go. And if someone identifies with this kind of thinking, I usually provisionally think of them in my head as somebody who might be appropriate for DNR and maybe DNI status as well, and someone who values quality of life and maybe comfort over longevity or other things. So once we get to here, then we go into that specific part of the code status discussion where we talk about risks and benefits and details and stuff like that. I have other patients who would say, on the other end of the spectrum, I value as long a life as possible. If I get so sick that I actually die in the hospital, do whatever you have to do to bring me back, even if it means pain and suffering and that I might not have the same quality of life I had before. And if someone identifies with this kind of a statement, I think of them as full code and would go forward to get assent describing CPR and mechanical ventilation for them, and think of them as somebody who really prioritizes longevity over other sorts of values. And then there are all the people in the middle who would say, I want to live as long as possible, but only if my life is of a certain quality. So do your best to bring me back, but if it seems like I'm not really going to get better, then talk to my family about letting me go. And these are all the people who I think tend to say, well, yeah, I want you to try, but I don't want to end up a vegetable. and I'm sure we've all had patients like that. They're not saying that they don't want us to try. And so I think of them as full code with a time trial, meaning that if this patient had an in-hospital arrest or needed to be intubated or something, they're not necessarily the kind of patient that we'd automatically assume would want to get a trach and a peg and go to long-term care or something like that, but they definitely want us to try. Awesome. Okay. So with those things in mind, this is the last case I have, which is, again, a very different flavor.
Then can I interrupt you for just a moment? Just to share with you, and I think everybody can see this in the chat, but just to reflect for you, that one of our interns shared that the middle is literally what they feel like 99% of patients say. And so I just want to take a moment and pause on that, because I think that that is obviously the stickiest area in terms of, especially when we're learning, right? How to have these conversations, and you're really learning and honing your clinical experience, and you're sort of like, well, I don't know, I haven't seen that many patients yet. How do I know if somebody's going to get better or not? And how do I know what that time limited trial is going to be? So I just want to pause for a moment and acknowledge that this can be really, really hard.
This is really hard. And I think, I think a lot of patients choose the middle or identify with that middle kind of statement, assuming that they can have it the best of both worlds, right? And that may not actually be true. And as you know, there's lots of things that go into how effective a resuscitation might be in an in-hospital arrest, right? What the cause is, how quickly it's recognized, things like that. And I think for someone, if you're having this conversation or using these sort of statements to get a sense of where someone is at, and you don't think it's very likely to happen in the hospital, I think it's probably okay to have full, enter a full code order and continue that conversation. And for someone like this guy who's already on BiPAP with COPD, obviously there's some balance that he's weighing between his quality of life, right, and longevity if he identifies with a statement like that. And that might be the time to take it a step further and ask, like, what would your life need to be like in order for you to want to keep going forward with this burdensome treatment? Or what kind of quality of life would you need to get back to in order to be happy, right? And that's a difficult question for people to answer if they've never thought about it before. And has less to do with medical treatments than how someone lives their life. And so involving family and things like that are really important, I think, at those stages, and something we can talk more about too. I think one point that I wanted to make, though, just with in this middle category, is that the patients who say they don't want to be a vegetable, I think that tends to trip a lot of people up, because we know that it doesn't necessarily work that way. Like if we try CPR, it doesn't mean that someone won't end up a vegetable. And so we're left with, okay, well, I can try if you want to, but I can't guarantee that you won't be. And I think the important point that I take away from this is that they are not at a stage of their life where they don't want you to even try. They do want you to try, but if it looks like they're not going to get back to a quality of life that's acceptable to them, then it's okay to change course after that.
Can I just add something really quickly, Allison? I think that's all really great. And I think just reminding ourselves in these moments, you all, that for a patient like this, who identifies with something like the middle statement, right, this isn't, this doesn't need to be the last conversation. Even if you're worried, even if the patient's on BiPAP, even if you think that they may be going to the MICU, I think that then identifying who is that person that you would want to make sure that we talk with. If you're, on BiPAP and you're not able to have this conversation more in a few hours, like, who is it that you want us to talk with? And calling that person early, whether it's a family member, whether it's a friend, a close confidant, calling that person early and just saying, hey, we're starting this conversation, and making sure that person knows that the patient has identified them, and summarizing and knowing that this may be a pretty iterative process early on in the hospitalization.
Yeah, I would also say that this stage of the conversation, when you're realizing they've never thought about it before, and we need to start someplace. This isn't necessarily, agreeing with this statement is not necessarily the end of this conversation either, right? If someone wants their quality of life to be of a certain standard or include certain things, I would ask them, like, what do you think undergoing CPR is going to get you? Right? Like, what do you think? What are you expecting or hoping that the outcome will be? And if their expectations aren't realistic, then that's an opportunity also to steer them towards something else, or steer them toward a different decision or a different treatment path that will help them actually achieve their goals of care, right? Which is maybe to get back to a state of independence or something like that. So this is a starting place. And this is really hard. Yeah. Thank you for bringing that up. I'm going to go for a second to the next case, which is of a different flavor entirely. This is a case that I actually had as a resident, a 101-year-old woman who comes to Harborview after a fall. The fall was most likely mechanical, but she was found to have a detectable troponin, and so is being admitted to cards. She has no chronic cardiac or pulmonary problems and no cognitive impairment. And her husband is at the bedside and recalls that she has a pulse at home, and I don't think it says DNR. How likely do you think, type into the chat or just unmute yourself, how likely do you think a code is for her, this admission? And how would you approach a code status for a 101-year-old woman who thinks she wants to be full code?
So we do have one OMG.
Yep.
Here. And then lots of possibles, a likely, and then, she's old, which is totally true. She is an old individual.
I think I got something very similar to the OMG page from the nurse, the bedside nurse that accepted her when I admitted her. And I think a lot of us would feel that at 101, like, maybe you're asking for a little bit too much if you want to be full code. But I asked her and her husband, what went into that decision? Obviously, they filled out a pulse form. It was signed by a doctor, and they had a conversation about it. And he just said to me that, she has declined quite a bit in recent years, physically, but not mentally. And she has just adapted so well to all the limitations she's had, and not been disappointed with herself or anyone else, even as her world has had to become smaller. And she's had more limitations. She's found new things to enjoy. And so she would probably adapt really well to new disabilities if they happened after a cardiac arrest in the hospital. And so this makes us all a little bit uncomfortable, right? I think at 101 to want to be full code. But the point I wanted to make is that it's okay to be full code, right? And I think our job having these code status discussions is really to find some realistic but goal concordant care for patients. And I think, in this case, being 101 is a risk, right, when you get admitted to the hospital. But I think, this patient was pretty much at her baseline, and I sent her home during rounds the next morning. And I think the point is that we went into a little bit more detail to find out, okay, you've thought about this decision, and does your reasoning make sense? Or is there some sort of education or steering that I can do that will help you have a more goal-aligned outcome? And in this case, maybe not. And so the point is that we took some time and figured out what her values were, and let her decision stand. And it's okay for a patient to have a code status decision that you don't agree with.
I'm going to interject again. I'm sorry, I'm doing so much introduction.
No,
Allison, do you want to share who is on the picture? Because these folks might get to interact at some point.
This is a friend of mine from medical school who agreed to have, or who allowed me to use this photo of her and her grandmother, who was in her late 90s, on roller coasters with her, and then actually died a few years ago of a stroke.
Yeah. I just really love that picture and story. And I will just also share that I just had one of my primary care patients. She's 98 years old. Lots of medical problems, lots and lots and lots of medical problems. Readmitted to Northwest for another episode of community-acquired pneumonia. We have spent 2 years having code conversations. She is full code. She went to the MICU. She was still full code. She recovered. She is home. She is off oxygen. So, every time I think I have a prediction about what's going to happen, I'm wrong. And so I just think it reinforces this idea that it's okay to respect, people's wishes at very advanced ages, even, when you feel like that may not be realistic. It's okay to respect and we should respect their wishes.
Mm-hmm. Yeah, I love it when older people surprise us.
Yeah, I think I also every moment I feel like I've encountered like a patient or a potential situation where I look at it and their code status, from what I either hear from the ER or in the system, seems kind of discordant with my initial reaction to their chart. Whether that be somebody who is full code at an older age or somebody who is DNR DNI at a very, very young age.
Mm-hmm.
I always I think I haven't had a whole lot of like super big surprises, but I've had enough to where I've learned that we should always just be like asking the patient like what's on their mind, because it's like amazing how almost all of them have a very well thought out and very like obviously patient centered, like it's all they've thought about it, and it just makes it easier to listen to them.
Mm-hmm. Yeah, and I think your instinct is really important to say if someone has a code status that surprises you, you should ask about it. You should ask how they came to that decision, and at the worst, it'll just help you to get to know them better, right? And what's important in their lives. But sometimes you will catch things that people haven't talked to them about before, right? Or give them some new thoughts that you can interject. And I similarly just had a very young patient in her 40s who had a sort of disabling GI illness and had lost a ton of weight and was, bound for a peg tube and came in all the time with abdominal pain, admissions like every few weeks for abdominal pain, was on disability, et cetera. And she wanted to be DNR, DNI. And that's uncomfortable, right? To look at someone and think, oh, you're very young, and this doesn't have necessarily a downward trajectory. And she just felt very strongly that her life was completely altered and hindered by this surgery that had gone wrong a few years ago. And she was a total burden to all of her family. And if things got any worse, like she wouldn't want to live through it and wouldn't want to put her family through that. And so hope for her that things do get better at some point. That's not her experience. And so we went with her DNR, DNI decision. Thanks for sharing that.
And that actually really reflects a comment in the chat, Allison, about the challenge of having these conversations, bringing up these conversations for young folks, young patients who have multiple chronic conditions.
Mm-hmm. Yeah, I think that's where sometimes the normalizing statements are helpful, right? But also I would just remind you that for a lot of people who have serious illness, and especially serious chronic illness, these thoughts have occurred to a lot of them, right? And even if they haven't explicitly talked to a doctor about them before, you're not going to be introducing these thoughts in their head most of the time, similar to the way that, patients who have suicidal thoughts, who are really depressed, we ask about it. And I think, we feel more comfortable in that context now, knowing that we're not going to sort of be suggesting that a patient, gets suicidal thoughts by asking if they already have them. And I think that's similar sort of with code steps discussions, that people have these things on their minds. And sometimes it's even a relief to be able to talk about it. One thing that I want to make very clear, and hopefully is clear to you already, but is not necessarily throughout medicine, capital M, is that DNR is not a philosophy of care. And so you will encounter patients, if you haven't already, who want to be DNR and are afraid to be DNR because they assume that when people see this in their chart, they're not going to give them the same kind of treatment that they would give other patients, or assume that they feel that they're sort of on their way out, and not give them, the best chance at everything else. And so I really like this quote from this book that's written by a palliative care physician at UCSF, intended for patients and their families with serious illness. And he says, "The challenge is that many people, doctors and nurses included, think that no code and DNR mean do nothing. That is, don't do anything to help patients live longer, which is simply not true. In reality, no code and DNR only mean that if you die suddenly, we won't try to revive you. The designation doesn't mean anything more. It also doesn't tell us anything about your preferences for other treatments. And we can do plenty short of CPR to help you feel better and live longer." And so be very cautious and very intentional. Also, when you talk with patients, that a DNR order is one very specific order about one very specific medical treatment. And there are many other medical treatments that come up much more frequently in someone's care. And just because someone is DNR doesn't mean that they wouldn't want dialysis or a surgery or a PEG tube or anything else. And so this sometimes can give patients permission and reassurance to choose something that's value aligned. I wanted to spend just a minute talking about COVID-19 and code status discussions around COVID-19. I know you guys have already had, right, a little bit of COVID teaching during ITC. There was a lot in the media about this a few months ago, right? And so I think advanced care planning and the idea of an ICU transfer, mechanical ventilation is much more on the public consciousness, or in the public consciousness, than it was just a few months ago. And different institutions handled this differently over the last few months when we had more COVID-19 patients. And just wanted to share my 2 cents of where things are at this point, and with a caution that things are changing all the time. But this paper was written by a group in Greece who basically looked into the literature and was like, great, like what are we supposed to tell our patients with COVID-19 when we're having code status discussions? Because a lot of code status discussions depend on someone's likely prognosis, right? And we don't know a lot yet about prognosis for people with COVID-19. So I would say know that most people with COVID-19, even older adults and geriatric patients, survive it. Know that there is some limited published data on prognosis of ICU patients, which is really what we need to look at when we're thinking about code status discussions. But that many of the patients in these studies were still hospitalized at the time of study publication. And that earlier this year, there was just such a focus on getting information, clinical information and evidence out there quickly enough for people to be able to use to treat patients, that we got some very grim statistics comparing how many patients survived or were discharged from the ICU, how many patients died in the ICU, and sort of a lot of us use that to inform our recommendations about code status. But actually there was a huge group of patients in these studies who were still hospitalized when the study was published, and so we don't know, what side that they're going to fall on, and what prognosis of someone in the ICU at different age or with different comorbidities really is. UW Medicine, just so you know, during this time sort of used a lot of this data, and there was an intention to make more recommendations for patients with certain underlying conditions and patients over a certain age to sort of recommend against intubation and mechanical ventilation if they had a COVID infection that was that severe. And we never reached, this was all based on evidence about prognosis and the potential benefit of mechanical ventilation, not about resource utilization, which I think is an important point. We never reached a point where patients could not be offered mechanical ventilation who might otherwise want it, or for whom it might be helpful. And so even patients who we might have made a recommendation to be DNI could choose not to assent to that and be full code, and that was okay. And I think we're constantly learning more, like I said, about the prognosis of ICU patients with COVID-19. So I would say going forward, as numbers are going up, I would defer making any recommendations about code status on the basis of COVID-19 positivity, because I think we just don't know quite enough. And instead focus on this opportunity to elicit goals and values, to focus on the prognosis of people's other underlying conditions, and whether or not a certain code status would make sense, even outside the context of COVID-19, and just having a really complete conversation, because this is also evolving pretty rapidly. Okay. The last segment, I actually don't even have a clock on my full screen here, so hope we're doing okay. The last section of this talk that I wanted to talk to you about is how to document your code status discussion. And this is kind of hopefully fast and straightforward, but what I want to encourage you to do mostly is just document what you actually discussed. I think often way more is going into code status discussions than is actually documented in the medical record. And often these conversations are iterative, as we've been talking about, and so having something documented is really helpful. So specifically, when you're entering admit orders in ORCA, there's this specific order for code status where you get to choose a code status, and then when you actually sign the order at this, or before you're able to sign the order, a free text box comes up where you can write a little narrative about what your code status discussion was like. And some that I pulled from patients on the wards last year went something like this. This was what was in the free text box. Patient states that he's full code, or patient confirms that he is DNR or DNI, which tells us very little information. And actually, in this case, these two text boxes were of the same patient a day apart. This is pretty confusing. And if you look in actually the progress notes, there was an incredibly thoughtful goals of care conversation that took place that was documented in progress notes, and that was just not documented with the code status order. So the point that I wanted to let you know is that these free text notes that you get to enter when you are writing admission orders are saved in a clinical notes section under advanced directives for code status notes. And you can put the information, that you discuss in these notes or in your H&P or your progress notes, and maybe just use this free text box to say, please see admission H&P from XYZ date for further details. But I would say the place where these code status notes have been really helpful have been particularly at Harborview that I've seen, when patients are found down and intubated in the field and come in, and we can't talk to them about code status, and they may not have any surrogate decision makers that we can identify or talk to quickly. And so having some documentation in the medical record from prior admissions is really helpful. And so I just encourage you to use this box when you have an opportunity. Briefly, what should be in your code status note? This is sort of the best practices version or gold standard version, who the conversation was with, patient's goals and values, prognosis, treatment options and outcomes, and the healthcare power of attorney, which kind of follows the same sort of informed consent idea. And as you can see in the box to the right, we don't often hit all the high points, but some examples for how to make something like this succinct are something like this. I had a conversation on admission with Miss R and her husband, who's her DPOA. She has advanced ILD, feels her quality of life is compromised significantly by her dyspnea, and unfortunately is not a candidate for lung transplant. She would like to maintain as much independence as possible in the time she has left. And given that CPR and mechanical ventilation would not help her achieve this, she prefers to be DNR DNI. Cool. Another one, sort of the opposite persuasion. I had a conversation on admission with Mr. T and his son, who's his DPOA. He has end-stage renal disease that is stable on hemodialysis. He's grateful for dialysis extending his life, has adapted to the intensive treatment, and would readily accept other forms of life support and associated burdens with the goal of more time with family. Thus, he prefers to be full code. I would say these are goals to aim for, but please just document whatever you discussed, because I think you're having much more rich conversations and are actually being documented in the medical record, and a few extra sentences would be really helpful. When you're looking for advanced directives, if you're admitting a patient, first on the bottom in ORCA, in the clinical notes section, there's alerts, advanced directives, code status. And if a patient has these, the forms on the right side of the box, healthcare directive and power of attorney, will show up with hyperlinks, and you can click on them to get PDF copies of their scanned advanced directives. And in EPIC, on the top up here, there's a section for advanced directives, and if a patient has them scanned in and on file, it will say received, and there'll be a link where you can click and look at those PDF advanced directives. And you can sometimes even do this, before you meet a patient that you're admitting. So anything in the chat before we get here? No, okay.
Nothing in the chat right now. Timing is perfect.
So some take-home points from the last hour. Just when you approach code status discussions in the ED, think about framing the clinical context before you enter that conversation, and make it a little bit more comfortable for you and the patient to go there. Consider using this algorithm or the versions that you guys suggested in the chat to determine the depth of conversation that you need to have, how much time you need to spend, and when it's really important to elicit actual goals of care in making decisions and not just a code status order. And then finally, please document your discussion, whatever it was. Some references, and that's it.
That was a really wonderful talk. I really appreciate that, because this is something I feel like from day one we've been having to do, and it's just so clunky to walk through without like this really great framework. Do you have any thoughts on, I feel like I've encountered a lot of, or more than I thought I would, like attendings or residents who, especially for younger patients, assume their code status. Mm-hmm. And I personally just don't think that's very patient-centered, just because I've try to, I guess, like be like that in the first place, but then B, I've been burnt a lot when I like even try to assume that. Mm-hmm. Do you have any like suggestions for, especially when younger patients are coming in or things are happening, to like, facilitate your team to make sure that you're actually gathering that information? Because it's important.
It is really important. I think the only patients that I assume code status on are the ones who can't participate in the conversation, right? And in that sense, we usually err on the side of life, right? of extending life. And so if a patient can't have that conversation, they don't have any surrogate decision makers to have that conversation with, then I usually put them as full code by default, pending any further conversation. But I think you're right that everybody, no matter what their age and what they're here for, deserves sort of being asked that question. And I think if a patient is younger and it's probably not going to come up and they're not that sick, then that conversation sometimes goes a little faster, right? For you to just put that as a normalizing statement and include that caveat, and say we ask everybody, and then that includes you. And I think that to me that kind of communicates some kind of respect, right? That somebody's getting the same treatment as everyone else, and we want to make sure that we're on the same page. And let me know if that answered your question a little bit.
Yeah, no, I think that it does, and I'll probably just like frame it that way. If I don't feel like I've necessarily gotten pushback, but I've definitely have like irritated team members because I like pursued a code status discussion with a patient whom they didn't feel needed a code status discussion, and that kind of just went against my values. So
yeah, I think you should absolutely pursue it. And I think this is the point, is that we like enter in these sort of informed consent procedures for other procedures only when it's really indicated. And we have code status discussions with everyone, even though a code might not actually happen. And so I think that might be an opportunity, if you are pressed for time or getting rushed by other members of your team, to consider using assent instead of like a really in-depth conversation, is sort of starting from an assumption that full code would make sense, and sort of test that with them and see if they agree.
Allison, there are a couple other questions in the chat that I'll share. And I just want to let folks know, please, I've put the evaluation code up. So please, while you're listening, do your evaluation. Evaluations are really important so that we get a sense of how helpful these talks are for you and can improve for next year. And I know we haven't gotten a lot of evaluations for the last 2 talks, so please do an evaluation. The questions are, do we ask a patient every time they're admitted about code status, number 1, and then sort of going off of that question, Allison, is a question about if somebody has a recent code discussion documented with their PCP, do we need to re-engage or should we re-engage in that discussion? Or what if their current decision differs from a prior quote unquote better discussion?
I confirm code status on every admission, right? Because I'm the one entering the code status order. So I want to have heard it from the patient and feel like I discussed it with them to whatever depth as I'm entering that order and not making assumptions. But I do start somewhere different. If they have advanced directives on file, or if they've had this, there's something in their outpatient record about a conversation with their PCP, or even if they had, a DNR or, DNR intubation okay or something, an alternative code status during their last admission. I try to confirm that with them if I think that still makes sense, and say, I noticed, I looked back in your chart and I know that you had this conversation with your primary care provider, or you had this conversation, the last time you were admitted to the hospital, because we do it every time, and that this was your decision at that time. Do you still feel like that makes sense for you? Or is it okay if we keep it the same this time? And sort of get assent to do that. And if you feel like the patient is really in a different clinical situation than they were when that conversation was had, I would feel free to say that. I know you had this really thoughtful conversation before, and it's great that you thought about these things. I think you may be in a different place than when you had that conversation before, and I want to talk about maybe making a different decision. I think this, I don't know if this is what you were getting at, Luke, but sometimes if patients in a calm environment in their PCP's office decide, to be DNR or DNI, and then they come to the hospital scared and want to be saved, quote unquote, and what do you do about that? I think starting with that, I know you had this conversation. I think I agree. I think that's really appropriate. So if it's okay with you, I'm going to keep that the same while you're in the hospital. And this is what we're going to do for you. Focus on the things that you are going to do for that patient rather than the things that they've decided to forgo or that you've decided not to do. Because even as things get worse, there is always medical treatment that we provide, even if it's palliative care, and that will make someone, can make someone feel better. Let me know if that answers your question.
Great, thank you. All right. I'm going to be respectful of everybody's time. Allison, this was super helpful. Thank you so much. I assume if there are more questions, they will come through in the chat, or feel free to unmute yourself. You can certainly interrupt me.
Yeah, I can stay around for a little bit if people want to ask questions.
Great. One thing I want to clarify, make sure people know is I'm going to have Allison's slides posted because I know there's a lot of great language in there that is nice to be able to practice. So I will make sure that the slides get posted for you. Cool. All right, everyone. I'll see you same time next week, and I hope everybody has a great week.
Likewise.
All right, Allison, as folks are signing off, thank you so much. Really appreciate your time as always.
Good to see you.
Yeah, it's great to see you too. Yeah, how's hospitalist life? I'm gonna stop recording us. Hold on just a second. I have to figure out how to stop recording us.